Hey, good morning, everyone, and welcome to UroNurse, your go-to place for urology healthcare education. And we come to you every Saturday at 9 a.m. Central Time. If you're watching us live, fantastic. Be sure to hit that subscribe button. We're this close to 2,000 viewers or 2,000 subscribers on our YouTube channel, so keep it up. If you've come to us for the first time, be sure to go to our website at uronurse.com, the best place to go to learn more about the show. Also, the best place to watch all of our past episodes, 105 past episodes. Holy cow. Couldn't believe how fast it's gone by. And if you want to listen in your car, no problem. Just go ahead and go to our UroNurse Plus area. We have an audio podcast on any of your favorite podcasting forums. This week, we're going to be doing one of our one contact hour sessions. This is on immunotherapy for bladder cancer. Bladder cancer has been one of my favorite areas to study, so I'm really looking forward to that talk. So let's go ahead and bring in our experts right now. Experts, welcome to the show. Hey, Lori, welcome. How are you doing?
Good morning, everyone. I'm doing well. Hi, everyone. Right. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology for 24 years now. Very happy to be here in Illinois. It's beautiful today. I think it's supposed to be in the 70s, so I'll take it for August.
Yeah, it's hard to believe. This is the dog days of August.
I know, it's crazy.
I almost had to put a sweater on this morning. It was so cool when I was outside, but I'll take it. Absolutely. My name is Vic Sinise. I'm the host, founder of UroNurse, and back in my studio. Yay! Glad to be back. I just got back from a neat trip. I know I talked about it last week, but I thought I'd fill you in a little bit more about the UroNurse connection. So we were traveling from Dillon, Montana to Yellowstone. And if you've never been out west there's not a lot to see, a lot of beautiful scenery, but no place to stop. You better fill up your tank because there's not a lot of gas stations, and you better make sure you got some snacks in the car because you may not find some place to eat. Well, we did find this little off the road dive bar, for lack of a better word, but turned out to be a nice place that we stopped at to have lunch. Pretty cool. We're in there. It had actually a guy singing country and Western songs and had a nice lunch. And then I saw this group of guys come in, and they were in these BMX motorcycle outfits, and they were just covered with mud. And as we're walking to the car, I walked up to one of the guys and started chatting with him. I said, hey, where'd you go? Where'd you ride at? And he's talking to me. He goes, what's that UroNurse thing? Because I just did the show that day. We jumped right in the car. I go, oh, so I explained what it was. He goes, I work for Olympus cystoscopy. So it's like, holy cow, this small connection. Then I'm in Yellowstone, and we're watching we stayed at a place right next to Old Faithful. So we were able to watch that geyser go off every 90 minutes if we wanted. But we're sitting there, and there's a guy with a drone, and I'm, a drone hobbyist myself, and he's flying his drone. So I come up, and of course I start chatting with him too. And turns out he works for an ophthalmologist. So I was telling him about the UroNurse program. He goes, he says, I got to do something like that. He says, our patients don't really know what they're getting into before surgeries. I think a video thing like that would be great. He goes, you'll have to, do you have a card? Can you tell me how you're doing it? I said, funny you should ask. September the 4th, Rally for Boot Camp, our monthly meeting where we decode the art of video streaming. Enlist for tactical sessions on cutting-edge techniques, intel on industry shifts, and a chance to appear live on my streaming program. Gear up, stay sharp, and gain the upper hand in the streaming battlefield. No experience necessary. All are welcome. There's a limit of only 10 live participants, the first 10 to register, and 200 spots additional available for watching. Questions can be submitted via the comment box. This event will not be streamed on any social media platforms, so no worries about appearing live online. And it all starts September the 4th at 7 p.m. Central Time. Be there to join us on Boot Camp. So there you have it. It's official. September the 4th, Boot Camp will open. It's going to be a once-a-month program. It's going to be at 7 o'clock at night on a Wednesday night, and you're all welcome to join if you want to learn more about how we do what we do. You'll get to be on the StreamYard if you want. You can be looking and watching it from the comments, but it will not be broadcast over anything except the StreamYard where we can kind of practice. So Maybe you want to see how you look on the video. Maybe you want to get some tips. We'll have different tips every month, and we'll see how it goes. I know that guy, that ophthalmologist, has said he's going to be joining. So you don't have to be in healthcare. Anybody can join. So anyway, that's my little plug for September the 4th. And of course, a pro like Lori has no problem. She could almost give boot camp, right?
You know, a little fun fact, I was a certified ophthalmic assistant before I became a nurse.
Wow. I tell you, it's crazy. I do periodically have the shirt on. I'll admit, that's shamelessly plugging the show. But people come up and ask me all the time, and they'll say, "Oh, I work for this company. It's a urology company." So there's a lot of us out there, and you just don't really know who's worked for who. And, a lot of healthcare workers, and we all kind of bond together over that common thing. But I never guessed that this guy flying a drone, real nice guy, he was telling me about how he's putting his daughter through college and sending her to a Catholic college. I go, "Oh, I know what that's all about. My daughter went to a Catholic college." So, but he was really nice, and it was kind of a neat time. All right, well, let's get on with our show, folks, and here we go.
All right, welcome everybody to this CME program. I have the pleasure of introducing Dr. Robert Dreiser from the University of Virginia. In keeping with the other speakers from this meeting, also internationally known expert speaker. We're very lucky to have him today. And again, I'd like to thank AstraZeneca for their generous grant to give us this lunch and give us this opportunity to learn from a true expert. So again, thanks, Dr. Dreiser.
So when I was looking at the program to see which colleagues and buddies were showing up here, I happened to notice that the good Ed Messing was going to be here. He's walked in here. I didn't know he would still be here. Okay, so it's even better that he is, actually. So I'm going to tell you a little story about a patient, but it also allows me to give homage to a mentor. So 1986-ish, I'm a young oncology fellow, and I'm going to see a patient of my colleague now, my mentor then, Dr. Skip Trump. Dr. Skip Trump is an internationally known urologic medical oncologist. Among the lessons I learned during my fellowship, this is a long time ago in uro-oncology. In that era, when I interviewed for a faculty position about a year later as a urologic medical oncologist, 4 academic medical centers, the chair of urology, refused to meet with me. And in one, they told the head of hem-onc that if I was recruited, I would never see one of their patients. That was the era. So let's flash back to my fellowship, where Dr. Messing and Dr. Trump were not only colleagues, friends, collaborators, but they were also both superb mentors, and I owe a great deal to both of them. The patient that I was going to see was a 56-year-old woman with metastatic urothelial cancer. She presented with metastatic disease, and Dr. Trump at that time treated her with a novel regimen of cisplatin, methotrexate, and vinblastine, CMV. MVAC was also obviously developed at that time. And she had a near complete response. This was now 18 months later, and she was admitted to the hospital for a seizure. She had multiple brain metastases. And the good Dr. Trump said to me, "Young man, I have never seen this before." Because, of course, nobody with metastatic urothelial cancer ever lived long enough to develop brain metastases. So the paradigm shift that occurred then was platinum-based. Fortunately, after 30 years of no additional progress, we are evolving into a new paradigm, and I'm going to share some of that data with you. So you all know this. Urothelial cancer is not an uncommon disease, and obviously when you consider non-muscle invasive disease, it's a very common disease, and clearly for a solid tumor, one of the most expensive diseases to take care of. It's the oldest median age for a solid tumor, right? The median age is about 73 years old, right? And we all know the comorbidities many of these patients face because we take care of them. And it makes it challenging to offer therapy across the disease spectrum. So 3 sort of aspects to this discussion. Briefly, some discussion about the role of selected immunomodulatory agents in non-muscle invasive disease. Then I'll talk about adjuvant therapy, perioperative therapy, and really where amazing changes have occurred over the last 6 months in advanced disease. So these are the SUO guidelines. This was published, of course, about, 7, 8 years ago and updated 2 or 3 years ago, and obviously is going to need to have additional updates. For a long time, as you're all extremely aware, the paradigm didn't change very much. There were certain things that unfortunately hadn't changed because there was lack of development of therapies. Focusing, just briefly for our conversation on the issue of high-risk non-muscle invasive disease, high-grade T1, CIS, you all recognize painfully about the BCG shortage. Whether the BCG shortage continues through next year or the year after is unclear, as the Merck facility, when it actually opens its doors and actually pushes out product, is unclear. So we're all still dealing with this issue. There's definitions about BCG failures. This came about by an SUO-led discussion with the Food and Drug Administration to give guidance to pharma companies about how to develop drugs and what the approvable pathway would be. And again, you're all very well aware of these definitions. It is a bit complicated, and obviously it's more complicated because what's an adequate course of BCG if you're giving a third or a half dose, et cetera. Those are the challenges you deal with every day. So in the sort of midst of the pandemic, Keynote 057 was presented. So this is a multi-cohort phase 2 trial of pembrolizumab for patients with BCG unresponsive high-risk non-muscle invasive disease. Pembrolizumab given systemically as we use it for many solid tumors and liquid malignancies. The data, such as it is, led to accelerated approval of pembrolizumab in this clinical setting. Let me just take a couple of minutes or a couple of seconds and just reflect on this. So this is an interesting development, right? This came, this is my bias. My bias is that the accelerated approval was influenced by a BCG shortage. I don't believe this data would have led to an accelerated approval in the absence of that because frankly, it's not that compelling. But in the absence of other therapeutic options, I think the FDA did what the FDA did. This is systemically administered pembrolizumab. Systemically administered pembrolizumab, even as a monotherapy, has toxicity associated with it. Although some patients, it's like rainwater. It has no issues at all. But when you have toxicity, you have real toxicity. This is sort of the longer-term data follow-up. This is still an experience of about 120 patients. So we're not talking, and this is single-arm study, and this is the best data that we have. Now, you are all very aware that we're moving into a different environment. Nadofaragene is approved by the FDA, although it is in a phase 4 program, primarily because they don't have enough product to allow people just to use it. So, for example, at UVA, we were part of the phase 2 study, so we got to be part of the phase 4 study, but we still don't have access to the agent. It's coming soon, and we have a waiting list. So it's going to be a little bit of a rollout. This is an interesting agent. There are other drugs in the pipeline that are similar to this. This is, of course, an intravesically administered therapy. It is extremely well tolerated. The data to date from the phase 3 program is at least interesting, and with longer follow-up continues to be encouraging. Here comes another one of my biases, all right? So I'm a urologic med-onc. I squirt drugs into people, right? I don't think there's any future for co-administration of systemically administered, at least checkpoint inhibitors with any therapy in this disease, at least in the United States. This is a disease that's managed by urologists. You know that even with pembrolizumab approval, the usage of pembrolizumab outside of some academic centers and large centers was essentially zero. The logistics, just the management of the disease and the complexity of these things are very problematic. I will tell you that at least at my institution, although we have an interdisciplinary program and we've treated a fair amount of people, I've been relatively underwhelmed with the utility of pembrolizumab, and we've certainly seen toxicity. As agents like nadofaragene, so this is the phase 3 trial and the data. These are ongoing trials. I don't believe that systemically administered therapy with intravesical therapy, unless the data blows completely out of the water, the intravesical therapy will become a standard of care in the United States. Just not going to happen. And I'm not sure that it'll actually blow it out of the water. I mean, I think a lot of the therapies, and there are probably 80 agents that are in development. These are just some of those agents. And we're not talking about, the pretzel. We're not talking about gemdositaxel. There's an enormous amount of novel therapies that will be completely under the control of urology. I think that's the future of the management of this disease construct. I find it very difficult to believe that the systemic toxicity of systemically administered therapies are going to be acceptable if the benefit is not dramatic. And I really frankly don't see that as a dramatic outcome. That's a bias, and obviously data can change my mind. All right, so let's move on to perioperative settings. So first, just a couple of cases. 67-year-old woman who presents with hematuria. She's got normal chemistries and a CBC or ECOG performance status is 1, TURBT, high-grade invasion into the muscularis propria. You see a cut of the scan. And she's got that little thing in the sort of peribronchial area that was about 1.4 centimeters and read as cannot exclude metastasis. She's a smoker. So you can vote on your using that QR code stuff. Given the following options, which would be your next step in managing the patient? Send the patient to your friendly med-onc or unfriendly med-onc, depending on your environment. 4 cycles of neoadjuvant platinum-based therapy. Expectant management, repeat the CT scan in 10 weeks. You got something else in mind. Either A or B are reasonable. You don't know. So go ahead and vote. All right, so both A and B are reasonable options. This is my patient. I opted to wait 10 weeks. That little ditzel didn't do anything. We proceeded with neoadjuvant therapy. She went to surgery, and she's about 18 months out, disease-free. So this is not an uncommon scenario of somebody with equivocal evidence of metastatic disease trying to make risk-benefit judgments, and obviously it's a shared decision-making because the patient's got to buy into the plan. All right, so since back in the 80s, up until now, but evolving differently, when we talk about advanced disease, be it sort of perioperative or certainly in the metastatic setting, the issue is, could you give the patient cisplatin or not? Why is that relevant? Because cisplatin and carboplatin are different drugs. Carboplatin is not as active as cis. You can cure people with cisplatin-based chemotherapy in the metastatic setting, and I'll come back to that in a bit. You cannot cure anybody with carboplatin. The neoadjuvant studies that changed the paradigm were cisplatin-based drugs. So that's why it was relevant to know whether you could give cis or not. What are the criteria that make somebody cisplatin eligible or ineligible? There's something, so about, 15 years ago, Matt Galsky, who's a world-famous urologic medical oncologist, he's in New York, he sort of gathered an informal group of folks who took care of this disease. I happened to be fortunate to be in that group. And we came up with recommendations, and they're called the Galsky criteria. And primarily, the two that drive most of the decision is renal function, not a surprise, and performance status. So if your creatinine clearance is better than 60 mils per minute, and your performance status is an ECOG 0 or 1, or maybe 1.5-ish, you can get cisplatin. At an academic medical center, we'll treat people with creatinine clearances down to around 50. But if it's much below that, you can't give it. So they're not eligible to get cisplatin. Why is that relevant? Well, there's no data to give carboplatin as a neoadjuvant therapy. So you either give cisplatin followed by surgery, if you're going to operate on the patient, or you take the patient to the operating room. This is another case. This is a 72-year-old professor of economics. Invasion into the muscularis propria, no metastatic disease on CT imaging, ECOG of 0. His creatinine is 1.2. He's got really good renal function. Must be that clean, living, economic professor kind of person. Neoadjuvant gem cis times 4 is given. His perioperative CT scan is clean, and he undergoes cystectomy and node dissection with a neobladder. He has an uneventful post-op recovery, surgical pathology, however, high-grade residual disease in the bladder, and 7 of 26 nodes are involved. So given the following options, what would be your recommendation for the patient? We thought maybe 12 answers was enough, but, carboplatin and gem times 4, surveillance, enfortumab vedotin, pembrolizumab, nivolumab, and then you see this sort of host of different combinations. Something else, or you don't know. Go ahead and vote. So here the answer is either surveillance or nivolumab. How could that be? All right. So adjuvant therapy for, we're going to just use, we'll talk about bladder cancer separate from renal pelvis disease. So for a long time, what happened is that if you happened to see a patient who had a cystectomy, who didn't have a conversation about neoadjuvant therapy, and that still happens a lot, the uptake of neoadjuvant chemotherapy, even after 35 years, is still less than half the people, better than it used to be. It's not like great. So we waited long enough and we're about to change the paradigm, so in the meantime, right, so if you didn't get it neoadjuvantly, it would be, there is data, not compelling data, but reasonable data to give it adjunctively. So that's what we would do, right, if you could get cisplatin adjuvantly. So that was the standard of care until several trials. I'm showing you 2 here. One, the designs are essentially the same. Surveillance with or without placebo control in one. Adjuvant immune checkpoint, atezolizumab or nivolumab. The atezolizumab study, stone cold negative. The nivolumab trial, positive for delay of metastasis-free survival, not overall survival. Accelerated approval by the FDA. Right. Now, interestingly enough, and something that I learned to my displeasure, I think it was at ASCO, the statistical design of the nivolumab study is such that I think you'd have to live another 500 years to know whether or not overall survival can be reached, because it was statistically designed to basically not be able to show it, which is very disappointing, but that's what it is. Now, next week, ASCO GU occurs, and the Ambassador study, which is an adjuvant study of pembrolizumab, will be reported. We're all very interested in seeing, whether there's a tiebreaker there. I think a negative study will, again, raise issues about, if you do enough clinical trials, one of them is going to be positive, right? That's why, they call them, randomized trials, and there's statistical significance. And if it's a positive trial, I think it increases some level of confidence of benefit from adjuvant therapy. This is the extended survival from the nivolumab study. And again, there is clearly a shoulder on the metastasis-free survival curve. Single-agent nivolumab is given monthly for a year. Generally well tolerated. Immune checkpoint toxicity does occur. It's manageable. Those of us who squirt things into people give lots of immune checkpoints, so we've learned how to manage these. So it's relatively straightforward. And again, once a month for a year. All right, so can we get smarter about how we do this? So ctDNA, minimal residual disease, right? So you may hear about people with colon cancer and other sort of solid tumors where MRD is actually increasingly part of the standard of care to decide risk of systemic failure, et cetera. In bladder cancer, a colleague of mine, Tom Powles, who's the head of the cancer center at the Barts Cancer Center in London, did a very important study, was published in Nature, based on ctDNA, but it was attached to the INVIGOR-010 study. That was the atezolizumab adjuvant study. What's relevant about that was, remember, that study was negative, right? But what they were able to do is to suggest that people with ctDNA positive disease did better with adjuvant therapy. So there's an assay that you can order to do this. I don't use this assay because I don't think it's been validated yet in a positive trial, but there are certainly clinicians who are doing this. I think that this is very intriguing, and more work is being done, and hopefully as this becomes more validated, we may be able to make better judgments, even in the context of metastasis-free survival only data. If you know a patient's at very high risk, then maybe there's a justification to give adjuvant therapy and maybe not in the patient with lower risk. So more to come about this. It is potentially very important in this disease. The ambassador study, as I referred to, is going to be reported next week, so look for that. So one of the things that I'm going to talk about in a few minutes is the paradigm-shifting developments that have already occurred in advanced disease. So one of the things that is important to recognize, and the enfortumab vedotin pembrolizumab data, which is completely paradigm shifting, has the potential to shift the paradigm even further. There are multiple perioperative trials that are ongoing. Neoadjuvant with adjuvant, neoadjuvant without adjuvant, chemotherapy plus an immune checkpoint, enfortumab vedotin pembrolizumab with adjuvant pembrolizumab. When, you all know about the EVP, I'm going to show you a little bit, I'm going to spend a little bit of time on that study because it is frankly the paradigm shifting study of my lifetime. That gives me some crotchety old bastards. I wouldn't use the word enthusiasm, but it does certainly give me the potential to believe that that study in the neoadjuvant, the perioperative setting, if that study is positive, the whole paradigm of management changes. Why is that so important? Not only because it's so active, as I will show you the data, but because it is agnostic to renal function and more agnostic to performance status. It's agnostic to renal function because the drugs that we're talking about are not renal toxins. And it's not platinum-based chemotherapy. I mean, it's not the most amusing treatment to give, but it's less toxic in general. So the potential to take a non-cis-eligible patient who is otherwise a candidate for surgery and use a therapy that moves the needle, that expands the population of patients who can get definitive local therapy, be that radiotherapy or surgery. So these are some of the trials. We'll see data from these within the next 12 to 24 months in most instances. These are studies designed for patients with cis ineligibility. Again, they tend to do worse in general. So this is also going to be very important to look at. And you'll notice that there are also things here, including the Sunrise 4, using the pretzel as part of the paradigm of management. So I'm talking to a group of urologists, right? So just bear with me here. People come to me occasionally and say, my urologist said I should have a cystectomy. And I went online and I see that there's this radiation stuff that you can give people. And I said, well, if you're in certain parts of the world, you wouldn't have heard about surgery. They would have said you're going to be radiated because that's the standard of care, right? And as you all know, to be honest with you, although there's the only attempt to do a comparative trial ended after 38 patients were enrolled, and I don't think we learned very much from that study. That was done before, other than Dr. Messing, any of you were around, okay? But we don't know. But when you look at concurrent data, that's actually several studies have been published recently, I think there's equipoise between these two options. The fact that we Americans have a bias about surgery is what we have. Other parts of the world believe that you can cure people with radiotherapy. So I tend to be agnostic. I don't surge and I don't radiate. I just try to give people advice. So I think that radiation therapy is underutilized for good performance status patients. Yes, expertise is relevant, right? I mean, you happen to be treated in Boston, you're going to get, rad oncs who treat lots and lots of bladder cancer. If you're in the middle of a state that will not be named, that's very rural, and the rad onc does a little bit of this, a little bit of that, maybe not so much, right? But by the same token, that urologist probably doesn't do cystectomies either, right? So, one of the things about this is that it's underutilized, and I think that's just the way of the world. When patients who are technically eligible for any approach or have an honest discussion about options, not an insignificant number of these patients will opt to have radiation therapy. All right, so the last case, 45-year-old man, hematuria leads to an ER evaluation. He gets admitted because he's got a hemoglobin of 4.8. He is in renal failure. He gets perked. His renal function gets a bit better, but it ain't great. He has a TUR, and he's got tumor into the muscularis. His chest CT is clean. Go ahead and vote. All right, so in the fall of 2023, all right, so 4 months ago, this was the paradigm of managing patients with advanced disease. Eligibility for platinum, neoadjuvant therapy. If you have metastatic disease and you walked in the door with metastatic disease, and 5 to 10% of people still do that, same deal. Are you eligible? All right, so in the 2023, all right, so 4 months ago, this was the paradigm of managing patients with advanced disease. Eligibility for platinum, neoadjuvant therapy. If you have metastatic disease and you walked in the door with metastatic disease, and 5 to 10% of people still do that, same deal. Are you eligible to get cisplatin or not? So from trials done small, relatively small, 400, 500 patient trials done back in the day, platinum-based chemotherapy versus something else. People live longer when they get platinum. 5 to 15% of people are cured. Who are they? Node-positive metastatic patients. Okay, I've treated a lot of people. We've cured people. 15% ain't great, but it ain't zero, which is why it was important to make a distinction. Now, I will tell you this, that in the community at large, a medical oncologist in the community will average 1 to 1.5 patients a year with metastatic UC. That's really hard to gain experience. So there's a lot of carboplatin used in the community. That's not a good thing. Now, fortunately, I think this paradigm is going to go away. Platinum-based chemotherapy was the standard of care. Upon progression, immune checkpoint therapy, level 1 evidence to supporting an improvement in survival. That was a paradigm. Following that, drugs like enfortumab vedotin, an ADCC, and sacituzumab govitecan. I have practiced many times with those, right? You learn how to say them, right? ADCCs and erdafitinib, a molecularly targeted therapy for FGFR2 and 3 mutations. That's the agents that we have. A lot of people have never heard of erdafitinib because if you don't know that you need to actually do next generation sequencing to look for FGFR mutations and amplifications, and you can't do that with ctDNA, you never know that you can actually use a drug like that. And probably in the metastatic setting, maybe 10 to 15% of patients have FGFR alterations. All right, January. It looks all different now, okay? So in the metastatic setting, the standard of care is enfortumab vedotin pembrolizumab, essentially for all comers except people who have active immune disease for which they are actively receiving systemic therapy. Not a lot of people. There probably still is a tiny pathway to use platinum-based chemo, GemCis, with an immune checkpoint. I'm going to show you the data. This is, again, you co-manage these patients, so your patients rely on you, especially when you send them to a med-onc who maybe they don't like, or maybe they don't trust very much. They're going to ask you, and you have to say, yeah, this is what the data shows, and you should listen to whoever. All right, frontline cisplatin-based data, so there you go. That's where the difference between agents came, and that's how we use these therapies. And there's a shoulder on the curve. Not a big shoulder, but it's there. Carboplatin, no shoulder. Median survival, 9 months. So that's why when somebody gives a patient who could potentially be cured carboplatin, they're doing them a disservice, right? So it's not the same drug in this disease. Okay, so the first level progress occurred a couple of years ago on this study. So I'm going to take a little time because it's important to understand the design because it's confusing when people start saying, well, which is better, right, without comparison. So Javelin 100. Patients came into the study after they received platinum-based chemotherapy. So Dr. X gets to pick. So he treats you with carboplatin, he treats you with cisplatin. Why? Because that's what he does. If you obtained stable disease or better, stable disease, PR/CR, you were eligible to be enrolled in this study. This study randomized patients between avelumab, an immune checkpoint, and best supportive care, just surveillance. Primary endpoint, overall survival. And in fact, it met overall survival. It actually moved the needle almost a year in terms of median overall survival compared to chemotherapy alone. When this data was first presented about 3 or 4 years ago, it was right before the pandemic, it changed the standard of care. Now, post hoc analysis, post hoc, which means take it with a grain of salt, suggested the people who got cisplatin before they went into the study did probably better than the people who got carboplatin. Not a surprise, but that was just hypothesis generating. So people get stable disease or better from platinum and they go here. Now, remember, there's level 1 evidence for pembrolizumab. You get chemotherapy, you progress, you get pembrolizumab, it improves survival. So people wanted to talk about that study and this study. But of course, the pembrolizumab study, everybody progressed. And then you give pembrolizumab and you get survival. Here, the people who progressed aren't on the study. So you basically, I'm not being critical of the study, you cherry pick the good people and you say, here's this therapy, right? That's why you can't compare them. But this was a standard of care. And in some parts of the world, they don't even have avulimab yet. So they haven't even been able to implement this particular paradigm. But obviously we can. Long-term safety, consistent with avulimab maintenance. And in this study, the avulimab went on basically forever. Most oncs who treat people with immune checkpoint will use 2 years. And if you're stable disease or better, will stop. That's not level 1 evidence supported. That's an extrapolation from melanoma. Okay, so I'll spend a few minutes on this. This was presented at ESMO. So I wasn't at the meeting, but I bought an online subscription, so I was watching the meeting. It was like a Sunday morning. I will tell you that I have never seen at either ASCO, the AUA, SUO, whatever, where the presenter gets 2 standing ovations during the presentation. Tom Powell's, again, the colleague of mine from Bart's Cancer Center, was the presenter. He's a very suave, sophisticated Brit. He's a brilliant guy. And he's also a very nice person. And he's standing there and he was like dumbfounded. I mean, who does this, right? It's like a game show. But the data was so compelling, that's what the audience did, right? I mean, you heard screams and raves because of the data. That's paradigm shifting to me, okay? All right, here's the design. Metastatic urothelial cancer, and basically GFR greater than 30. So, not everybody, but a lot of people. ECOG performance status 2 or better. Randomization between enfortumab vedotin and pembrolizumab. Enfortumab vedotin is squirted weekly. In this study, 2 out of 3 weeks. So it's an IV administration. The pembrolizumab is given once every 3 weeks. Enfortumab vedotin is an ADC. It has toxicities. Its major toxicities are skin and neurotoxicity. And they can be nasty. You really have to know what you're doing. It can also cause diabetes acutely. Not permanently, but it causes hyperglycemia. So it's, you got to be careful with the drug. All right. The randomized arm was chemotherapy, basically cis or carboplatin based on criteria, right? So if you should get cis because your renal function and performance status was good, you get cis. So this wasn't dealer's choice. Endpoints, progression-free survival and overall survival by blind or by independent review. All right. This is the progression-free survival difference. Look at that. Look at the p-value and look at the hazard ratio, 0.45. Everybody, whatever group you are, whether you have liver mets, age, everything, benefited. Here's the overall survival benefit. A hazard ratio of 0.47. This is astonishing in oncology. You don't see this, all right? I mean, that's why people stood up and screamed, because this has taken almost 40 years to move the needle. I have patients on this study. 2 of them who were randomized to the experimental arm are now 2 years out after completing 2 years of therapy. They're cured. Or at least they're not likely to die of the disease. Okay, probably not fair to say they're cured, but they're not likely to die, right? With metastatic UC, you live 2 years without recurrence, progression, you're cured, essentially, right? So I have a host of patients who got immune checkpoint who are also out this far. Now, the challenge for immune checkpoint by monotherapy was, about 20 or 30% of people get really outstanding responses, the other 70%, right? So good for the 20 or 30%, but not so good for the other 70. But here, a hazard ratio of 0.47, right? So this is really an amazing therapeutic benefit, right? So it's not the easiest therapy to tolerate. You can tolerate it. What happens is you can only give so much enfortumab, so you get 6, 7 cycles, and you just have to stop. People get beat up. They start having toxicity you can't fix, and then the pembrolizumab continues, right? So today, in the United States, this therapy received an accelerated approval shortly after this presentation for non-cis eligible patients. And within the last month, it received formal approval for all comers. So this is now the standard of care. These are the adverse events, and I've sort of described them to you. So, you get nothing for nothing. It's toxic. And there's the approval. Okay, so imagine this, a little more theater at this meeting, right? So the Europeans don't have the same flair. So if this was like the AUA, it would be the last presentation of the last. Same at ASCO, right? Because they want to make you want the audience, the last presentation. The EV was the first presentation of the session, right? Now comes this presentation. Talk about, tuxedo with brown shoes. This poor guy, who's also a very distinguished urologic medical oncologist, gets up and presents positive data following 2 standing ovations. He did not get a standing ovation, okay? All right, so this is nivolumab and GemCis, all right? All right, so this is Checkmate 901. These are patients with metastatic disease, and the randomization was GemCis nivolumab versus chemotherapy. Now, some perspective. 3-4 years ago, we had 2 large trials that were 3-arm studies. Chemotherapy alone, immune monotherapy, and combination therapy. Both trials, very well done, huge studies, completely negative. No value to add immune checkpoint to chemotherapy. Also called into question the role of immune monotherapy as an upfront treatment. That's another story. So this was the 3rd study, right? So there wasn't a lot of expectations here, all right? But in fact, it moved the needle. There was a survival benefit for patients, and it was not inconsequential. Had this study been presented by itself without the prior study, people might not have gotten up cheered, but this would have come out as the standard of care. So talk about oh, okay, nice, very nice. Okay, that's what this was, right? Now, so when I suggested earlier that for patients with node-only metastatic disease, if they walked in the door and they could get cisplatin, and the patient says to me, hey, doc, which is the best therapy for me, this EVP stuff or this? I would have to basically say to them, I know I can cure a subset of people, and you're in that group, node-positive patients with cisplatin-based chemotherapy. I know this because I'm old and I've seen it and we have data. And now we have data that shows adding an immune checkpoint probably improves it again. Now, I obviously raved about EVP like it's like I own stock. I do not own stock, but it's good stuff. But I don't actually know if I'm curing anybody. So it's that group of patients that I might still consider this as an option. So chemotherapy upfront is not quite dead, but it is sort of going to probably go away. All right, the last couple of minutes, immune toxicity, right? So one of the things about immune checkpoints is, medical oncologists tend to, we take care of a lot of problems and we work hard not to be somebody's primary care doc, mostly because I would be 1, incompetent, and 2, I'd blow my brains out if I had to deal with what my primary care colleagues deal with, right? But we take care of everything because they bring everything and they just expect us to take care of it, right? So we talk about, being an internist. I was trained as an internist. Okay, I'm not boarded anymore. I'm old enough to have been lifetime boarded in medicine, but I would never take the boards again, right? But I will tell you, when you give immune checkpoints to people over the last 7, 8, 9 years, the kind of stuff that you see is just frightening. You see immune toxicities of amazing proportions, and you'll see things and you'll say, I know this is immune toxicity, but I don't even know what to call it. There's no syndrome. I can't, right? I'm dealing with a guy now who's got urothelial cancer. He's 80-year-old guy, he's in good shape. he had a very nice response to immune checkpoint about a year and a half, where now he's progressing. So he's been off therapy for a year and a half. He developed this horrendous oral pain and bleeding. So he goes to the dentist, they send him to an oral surgeon, send him to an academic oral surgeon. The academic oral surgeon calls me and says, "This is immune toxicity, I've seen it before." The guy hasn't had therapy for a year and a half. But just because you don't squirt the drug into somebody doesn't mean that the immune impact goes away. So the guy's on 60 of pred and he's getting better. But it's amazing the kinds of things we see. So you'll see a little bit of a time curve. That's just nonsense. Immune toxicity happens when it wants. It can happen early. It can happen late. It can happen. It's one of the reasons why not only don't I believe, you already heard me talk about, I don't think there's a role for systemic immune therapy in non-muscle invasive disease yet, because there's no data that's compelling. Unless it's extremely compelling, it's because you don't want to do this, okay? I mean, it's just like, you got enough to do. This is hard, and you have to have a team. It's not just me. I got to, my APP, my nurse, we do this all the time, and it takes a village to fix this stuff. This is not fun to do, all right? So you really want people who sort of do this for a living to do it. There are lots of guidelines for toxicity management. I'm not going to belabor that because fortunately for you guys, most of the time you don't have to do that. We grade it, if you get grade 3 hepatitis, I can retreat you, right? Because that's transaminitis. It gets better, I treat you. If I blow your pancreas and you're now insulin dependent, and unfortunately that happens, I can't hurt your pancreas anymore. You're on insulin, so we retreat. But you get pneumonitis or myocarditis, we're done, because I can kill you. So those are the kinds of things that we sort of figure out and make risk-benefit judgments. All right, the last 2 slides are about interdisciplinary care. So I started by talking about interdisciplinary care. The diseases that we take care of are too complicated to not have a team, right? I mean, I rely on my urologic oncology colleagues, my rad-onc colleagues, and a host of others, my APPs, et cetera. But, I've been fortunate to work in academic centers my entire career, and my best friends and my closest colleagues have always been uro-oncologists. So when you work well together, the patient does well. The challenge for our colleagues is that there are folks in parts of the country where they don't have a very good working relationship with the med-onc. Maybe the med-onc doesn't really see the disease very often, and you don't trust them. Okay? I mean, stuff like that happens. They're your patients. You got to trust, right? So it's hard, but in academic centers or in big community centers and big government centers, this is the way we take care of patients, and it's obvious that people do better when we do this. And shared decision-making, obviously that first patient I showed you that had the ditzel in the lung, that's what we do all the time, right? We say, look, this is what we think, here's our choices. The patient says, well, if you delay therapy, am I going to be more likely to develop further disease and die? All right, you got to figure it out together. All right, so just last observations. As urologists, you're in sort of the golden age of novel therapeutics for high-risk disease. And remember, as you well know, although we spent a lot of time talking about the high-risk patients, the patients that you see more frequently are the patients with intermediate and low-risk disease, and it's an expensive disease. So the potential for some of the therapies to move earlier in the disease is obviously on the minds of pharma, right? Because they know where the money is. But it's also potentially good for patients, which is why it can't have significant toxicity. You can't take a patient with low-grade, low-stage disease, even if it's recurrent and multifocal, and have their ears fall off from a therapy, right? There's got to be something that can be managed. Fortunately, I think there are agents that you'll see in more advanced disease moving earlier that hopefully will begin to impact on that. No question that immune checkpoint therapies has altered the natural history of many patients, not enough patients. And how to figure out who the people are going to benefit, the development of therapies for people who have acquired or primary immune checkpoint resistance is a huge area of study, not just in urothelial cancer, but all of oncology. EVP is a standard of care. It may not be the standard of care, but it's close to it. Knowing how to give it, knowing what the side effects are. Even as urologists, you should be at least facile with what it looks like so that when the patients ask you for your opinion, you can have an informed opinion and help them have some confidence in what's going on. And if it moves into the perioperative setting, you clearly are going to need to be engaged because, you have to decide whether or not, and we don't know any of this yet, if you whack somebody's bladder after EVP, is it like doing a post-chemo RP on D? Okay, is it like stuck? We don't know those things yet. We're learning these things, right? Again, Gem-Nevo, maybe for node metastatic patients. And again, we're now just beginning. Pharma figured out that urothelial cancer is a disease with lots of people, and now pharma, there are more studies than we can get done, which is a good situation to be in, so that 20 years from now, somebody can look back and say, oh, how stupid they were, all right? Thank you very much.
So if you want to obtain your contact hours for this presentation, go to the link that's going to show up shortly on this uronurse.com website underneath the show. And it'll bring you to this area. You're going to have to do the pre-assessment. I've already done it, so it's not showing up, but that'll be your first step. Then you'll hit next. And it's going to bring you to the first slide. Now, of course, I recorded these together, so you don't have to go through it. You can just slip right through. It'll bring you to that next button. You're going to have to answer the question and hit next. And then again, of course, I answered them, but you get through that. The same thing, you get the idea. You can skip through till you hit to the next button. Since I've already answered the question, it's not allowing me to show you that, but you'll answer that question. Again, you'll get to the next slide, advance through, hit next, and then next. And this, I think, is the final slide you'll need to go through, and then hit next, up or down, doesn't matter. And then you'll start your post-assessment. Now, this is how you'll end up getting your CE at the end. I'm not going to go through the answers, so you'll have to do that yourself. Thank you. Oh, so there we go. To me, that guy was fascinating. I just I could listen to it over and over again just to try to grasp some of this new therapy. What do you think, Lori?
It was overwhelming. You think you know it all in urology, and it's like you don't know anything when it comes to oncology drugs and things like that. So it was interesting. Something I probably should look into learning more about as well, just because patients do ask about that stuff when they come in.
I will say that I watched this now for the second time because I obviously I went through and recorded it so I could make it, instead of 4 broken up videos, one cohesive video. Better the second time around because I kind of grasped things and I had some notes that I wanted to check things out on. Keytruda, is there anything it can't cure? I mean, that Pembrol. The other thing I love about this guy is he could just let those things roll off his lips. I can hardly say those.
That's the hardest thing about the whole thing. I was just impressed at how he said the words.
Yeah.
So right. We had a couple of comments, and Heather said, "Wow, that's a lot of data," and Fran said, "Agree." It was,
yeah. It's tough. I mean, I knew a lot about bladder cancer because I was involved in BCG when it was in the studies. I was one of the study persons in that. And then once BCG got rolling, then I remember a guy by the name of Michael McDonald, a urologist, who started doing the interferon A additive to it, and listened to his lecture. And, it was amazing to me how little they knew about BCG, except that, hey, it works. I mean, right down to what the right dosages were. And he did a lot of studies to show, you could give far less than 6 doses and half dose dosages instead of the full dose for toxic patients who had toxicity. So back when I thought I knew a few things, now I'm like, oh man.
Now I'm just learning about gemcitabine and the docetaxel.
Yeah,
past that.
But these checkpoint inhibitors and again Keytruda, which seems to cure everything. Thank goodness. It's really got. I mean, when you see an oncologist get excited about data with the EVP, that says a lot. Mm-hmm. So, well. Hopefully you guys can all get your contact hours, take the quiz. You got to pass it. So if you watch the video, you should be able to pass it. If you didn't, good luck. But as I did that little demo at the end, you just kind of zip through those slides, through the videos, and then you can get to where you need to be right away to the end and get your contact hours. I managed to skip through and get mine, so it's doable. But it is a challenge. So I'd say take questions, but I couldn't answer them.
Yeah, I'm glad you feel the same way, Vic, because I don't think I could either.
But I will put this out there: if there is a oncology nurse that watched this, or urology oncology nurse that watched this, I'd love to have you on the show to kind of pick your brain and talk a little bit about what you do, because we know it's the physicians are talking about the drugs, but it's the nurses that are giving these things. So I'd love to get one of you that are actively doing this to contact me. Just go to UroNurse.com. There's a contact UroNurse or ask UroNurse. Just put the information in there. I'll get in touch with you, because I think it'd be a fascinating subject. This is really, for me, it's promising because, back in the day, it was, BCG failure, cystectomy, and, ultimately people didn't survive. But now there's some additional hope.
We have one more comment here real quick.
For go ahead.
Heather. She said where she works. We are just starting to give, and I know she threw this name in here just to stump me because I don't know how to pronounce it. Adstiladrin and gemcitabine with a combo med that I can't remember.
Oh, great. So Heather, if you're one of those that's involved in this, hit me up. Let me know. Oh, there we go. She's going to check with their radiation oncology navigator to contact you. Yeah, thanks. Awesome. I think it'll be a great talk. And that's one of the things I really love about this program is sometimes, we get inspired about what's the next subject. Back when I started this, almost 2 years ago now, I was like, how do I come up with 52 episodes a year? Now people reach out to me and say, hey, would you like to have me on your show? So it's helpful, but it's still always good to have new subjects. So I think it keeps it interesting. Speaking of new subjects, next week, we're going to do another contact hour. So you get these contacts, fill them up. This one's a little different, and I'll put the promo on for this.
In a world where information is everywhere, it becomes important to be able to analyze the literature. This presentation reviews reputable sources of medical literature, how to assess the study, and how to interpret the results. The speaker discusses how to assess the originality of a study, scientific quality, reliability, validity, and reproducibility. Study bias and quality control are also reviewed. This program is eligible for 1 credit hour. Join us next week to learn more at UroNurse.com.
So yeah, we're always reading through these studies, and some of the words, even in this last thing that he was throwing out there, hazard ratio, and all these things that, back in the days when I took statistic, I was a little bit more back in the day, 40 some years ago when I took my statistics course, I was really up on it. But I think this might be interesting, kind of learn how you read through these reports and make sense of things and kind of make a good judgment call. Even in literature, and there's some, as Trump would say, fake news. So, all right. Well, I hope everybody has a great rest of their weekend. This is like the best day. We have a family party coming shortly, and we're looking forward to that. How often in August you get this kind of weather? So rare. Usually we got people coming over and they're just sitting out in the sun baking, but today's perfect. So looking forward to getting together with my cousins. And the rest of you have a great day. Also, don't forget to check out our UroPatient podcast, which is at uropatient.com, coming at 10:30 after this. And hey, that's it. Have a great week. See everybody next week.
Bye.